Namaskar, welcome to PK's classes. Today we are going to discuss about the pathogenesis and treatment of Parkinson's disease. Parkinson's disease is a progressive neurodegenerative disorder, a common movement disorder. The symptoms are tremor at rest, muscle rigidity, akinesia, loss of movement, bradykinesia, decrease in movement, dyskinesia with pain. Wherever DYS is there, that means pain is associated. There may be a problem in balance and get the walking pattern. It was first described by James Parkinson in 1817 and accordingly it was named as Parkinson's disease. In Parkinson's disease, there is loss of dopaminergic neurons from substantia nigra to corpus striatum. The substantia nigra consists of two subregions. One is pars compacta and the other is pars reticulata. From the pars compacta, SNPC or SNC, the dopaminergic neurons are supplied to corpus striatum, then cholinergic neurons are supplied to cerebral cortex, spinal cord and skeletal muscles. In the skeletal muscles there are nicotinic acetylcholine receptor, alpha 7 nicotinic acetylcholine receptor. All the 5 subunits are alpha 7 in this receptor. And dopamine function is inversely proportional to acetylcholine. So when there is loss of dopaminergic neurons in the nigrostriatal tract, there will be excess activity of cholinergic neurons, that is inversely proportional. Loss of dopaminergic function, increase in cholinergic function, and because of that will lead to the function, the symptoms like tremors, muscle rigidity, akinesia, dyskinesia or bradykinesia, balance problem. So all these are the symptoms of Parkinson's disease. That means if we want to treat this, then we have to supply dopamine to this area. Then there is also glutamate excitotoxicity. Glutamate acts on the glutamate receptors like AMPA and NMDA. NMDA is N-methyl D-aspartate. AMPA is alpha amino 3 hydroxy 5 methyl 4 isoxazole propionic acid, and that leads to excitotoxicity because of increase in intracellular calcium, and that causes striatal degeneration through apoptosis and leads to Parkinson's disease. So we need dopamine in the brain, and we will administer dopamine through different routes, but unfortunately dopamine cannot cross the blood-brain barrier. Dopamine cannot cross the blood-brain barrier. So this is the blood-brain barrier, this is the periphery, this is brain. From periphery to brain, dopamine cannot cross. So we have to use the precursor of dopamine, that is dopa, dihydroxyphenylalanine, and we need to use the levo form of dopa, levodopa, which can cross blood-brain barrier, and this levodopa can be metabolized by two enzymes. One is dopa decarboxylase or aromatic L-amino acid decarboxylase AADC, and two is COMT, catechol O-methyl transferase. In the periphery, if levodopa is metabolized to dopamine, then dopamine cannot cross the blood-brain barrier. So if you see, almost 90% of levodopa is metabolized in the GIT to dopamine, 9% is metabolized in the blood, only 1% reaches the brain. So the levodopa dose is usually 250 mg. So if we can give a dopa decarboxylase inhibitor which will act peripherally, then more amount of levodopa can cross the blood-brain barrier. So when we use a dopa decarboxylase inhibitor like carbidopa, 10 milligram of carbidopa, the dose of levodopa reduces from 250 mg to 100 mg. So one, we can use a precursor of dopamine, that is levodopa, which can cross the blood-brain barrier and then will be converted to dopamine in the brain. Second, we can combine levodopa with a dopa decarboxylase inhibitor like carbidopa benserazide. Then this dopamine can be metabolized by two enzymes, monoamine oxidase and the isoform B, MAO-B, and catechol-O-methyl transferase, COM. So usually the monoamine oxidase, the oxidation is followed by further by action of aldehyde dehydrogenase, because initially there will be oxidative deamination of this dopamine. Oxidative deamination will be there and it will be converted to CH2CHO aldehyde. Then by aldehyde dehydrogenase it will be converted to acetic acid. So 3,4-dihydroxyphenyl acetic acid or dopa from dopamine will be there from MAO. So dopamine can be metabolized first by MAO followed by COMT, or first by COMT followed by MAO to produce homovinylic acid or 3-methoxy-4-hydroxyphenyl acetic acid. And MAO is usually followed by aldehyde dehydrogenase. So in the metabolism of dopamine, the oxidative deamination by MAO or MAO-B will form the aldehyde, which will again be converted to acetic acid by aldehyde dehydrogenase. Again in the periphery, dopamine produces number of side effects. There will be mainly cardiovascular side effects like postural hypotension, tachycardia, arrhythmias, and endocrine functions like decrease in prolactin secretion. And dopamine in the brain can act on the chemoreceptor trigger zone to produce vomiting. So these are the side effects associated when there will be dopamine level. So levodopa will be converted to dopamine both in periphery and in the brain. So we have discussed the first two types of drugs. One is precursor levodopa, second levodopa plus dopa decarboxylase inhibitor, third we can use MAO-B inhibitor, and fourth we can use COMT inhibitor. These 3 and 4, MAO-B inhibitor and COMT inhibitor, can also be used in combination with levodopa. Then in the pathogenesis there is a role of the cytosolic protein alpha synuclein, which in presence of the reactive oxygen species and maybe due to genetic mutation will convert alpha synuclein to its oxidized and aggregated form, which will undergo apoptosis, and there will be loss of the dopaminergic neurons or the substantia nigra neurons, and the remaining neurons, these oxidized and aggregated forms of alpha synuclein called Levy body are present. So loss of substantia nigra neurons and presence of Levy bodies in the remaining neurons are the hallmark pathology of Parkinson's disease in its final stages. And these reactive oxygen species or oxidative stress, the glutamate has a, so we can use glutamate receptor antagonists. So we can either use AMPA receptor antagonist number 5 or NMDA receptor antagonist number 6. Then MAO-B also metabolizes 1-methyl-4-phenyl 1,2,3,6 tetrahydropyridine MPTP to MPP plus, which causes the production of reactive oxygen species, which leads to oxidative stress, neurotoxicity, neurodegeneration, and symptoms of Parkinson's disease. MAO-B, during this conversion of dopamine to dopac, there is also generation of hydroxy free radicals, reactive oxygen species, oxidative stress, and Parkinson's disease. So MAO-B already we have discussed. Number 3, MAO-B inhibitors can be targeted so that it can decrease the oxidative stress induced neurodegeneration. So now we can enlist the drugs used in Parkinson's disease. So first, drugs that increase dopaminergic activity, dopamine precursor like levodopa, and peripheral dopa decarbonylase inhibitor like carbidopa, benzodiazepines, which are used in combination with levodopa. So levodopa, when there is the dose is 250 mg, and when we use the DDC inhibitor 10 mg of carbidopa, the dose reduces to 100 mg. Then number 3, dopamine metabolism inhibitors. In this, MAO-B inhibitors, selegiline, rasagiline, sulfinamide, and COMT inhibitors, which can inhibit the metabolism of both dopa and dopamine. For example, entacapone, tolcapone, opicapone, nebicaine. Then that dopamine acts on the dopamine receptor. So dopamine receptor agonists like bromocriptine, pergolide, ramipexole, ropinirole, rotigotine, carborgoline, lisuride, apomorphine, all these things we can use. Also, we can use the dopamine releasers, which will increase the release of dopamine from the presynaptic neurons, and we can use the drug amantadine, which will act as dopamine releasers. But these drugs are rarely used. So, up to this, widely used drugs, up to this, and after this, the drugs are very rarely. As we have already discussed that there is loss of dopaminergic function, so there is increased cholinergic activity, so we can use the drugs which can decrease the cholinergic activity. The central anticholinergics, which are antagonists of the alpha 7 nicotinic acetylcholine receptor antagonist, and trihexyphenidyl, benztropine, biperidine, these drugs can be used. And the antihistamines like orphanadrine, which are used because of their anticholinergic function. Antihistamines also show anticholinergic function, and because of that we can use. And the recently used drug, this orphanadrine, which is having antihistaminic as well as NMDA receptor antagonist action. Diphenhydramine and promethazine can also be used in case of Parkinson's disease, but all these drugs are rarely used. In addition, there can be this recent anti-epileptic drug perampanel, which blocks the development of alpha-synuclein pathology by modulating neuronal activity. So this is initial findings in experimental models of Parkinson's disease have shown good results, and this can be a future drug, perampanel, the AMPA antagonist, in case of treatment of Parkinson's disease. So this is all about the pathogenesis and treatment of Parkinson's disease. Thank you.